esteemed colleague, Dr. Smylie, is I'm going to light some more smudge for us, because that's what we do when we're having a stressful day, when we are going through something, when we're holding a hard truth. We bring a little bit of medicine to help us carry it. And it can be medicine of all kinds. It can be a medicine that you light with a fire, but it can also be a stretch and a gentle walk outside, appreciating the sunshine. It can be watching your cat roll on the floor. It can be playing with children, because children are good medicine. They bring us joy. I know you mentioned that your daughter says, "I love you," like 10 times. And the first thing I thought, I was like, oh, so you have sunshine inside your house. That's beautiful. How wonderful. So keep all those good check-ins, those sunshines in mind, because I promise you, all of what we're doing today is trying our best to do something better than what's been done before. Okay. So with that, I'm going to introduce my wonderful colleague, Dr. Janet Smylie. I'm going to read your bio, unless you don't want me to read your bio, but I can. But I'll read some of it. So we are among genius, folks. So my dear friend, Dr. Janet Smylie, is the director of the Well Living House Action Center for Indigenous Infant, Child, and Family Health and Wellbeing. She's the Tier 1 Canada Research Chair. That's the highest tier, by the way, just so you know, in advancing generative health services for Indigenous populations in Canada. And she's a professor at the Dalalana School of Public Health, University of Toronto. Her research focuses on addressing Indigenous health inequities in partnership with Indigenous communities. This slide makes a lot more sense when you hear what she does. She's particularly focused on ensuring all First Nations, Inuit, and Métis peoples are counted into health policy and planning wherever they live in ways that make sense to them, addressing anti-Indigenous racism in health services, and advancing community-rooted innovations in health services for Indigenous populations. She maintains a part-time clinical practice at 7th Generation Midwives Toronto and has practiced and taught family medicine in a variety of Indigenous communities, both urban and rural. A Métis woman, Dr. Smylie acknowledges her family, traditional teachings, and ceremonial lodge. I couldn't just stop partway through. There's so many beautiful. She also runs marathons. What? I don't do that. I barely get off the couch when I'm not working. So, Dr. Smylie, if I'd love to welcome you up. Please welcome her with a wonderful round of applause. Thank you. Switch over. Thank you. Oh, that's it. Okay.
Hi, everyone. Hi, Michaela, for opening us in a good way, for bringing this medicine, and for the invitation to speak this morning. Yeah, and I just want to say Tanzi Atawia. So hello, how are you? Our greeting on the prairies. One greeting that we have anyways, the Tanzi, it's really how are you, right? So not just hello. And then we could say kakia kittens, kitatan skatanawau, which is a beautiful verbal, like interactive greeting. So greeting everybody in a good way, which I tried to do this morning. So I hope everybody's now ready for some complex thinking. So now that we're going to stretch ourselves today, right? So we've stretched our hearts. And yeah, hopefully we've fortified our spirits just a little bit. And now, and because we're scientists here, right? I'm going to challenge your brains. And I want to frame it that way because sometimes people think, oh, like we're going to try to engage like First Peoples, right? Like that's going to be nice. It'll be easy, right? And a lot of times, like non-positivist knowledge systems, right, are framed like as simple, right? And yeah, easy, right? Pleasant. And there's a way in which institutions like this can downgrade them, right? Essentialize them, oversimplify them. So I think that's a real loss because as somebody who has spent quite a lot of time at the interface of knowledge systems, I think it's important more than ever that we draw on all the different kinds of knowledge systems that we have in the world, right? To solve the huge problems in the world, right? Because, yeah, a pure hypothesis driven, wet bench scientific method is not helping us in isolation. So it's awesome. I've spent a lot of my career figuring that out. My dad was actually an applied scientist and an applied physicist. Yeah, I actually like human systems and human social systems, and because I think they're more complex and more interesting. But if we use those models, because you're here, so the models that will help us, like in a lab, right? Like figure out like a molecular pathway, right? Or figure out like drug A and drug B. You don't want to contaminate your model, right? So you want to have clear questions. That's a really good model. But then if we're trying to ask a complex question, like what are the drivers of persistent unequal distribution of health and social resources, right? Why do First Peoples not participate like in clinical trials, right? Why is mitochondrial research of very limited social value to First Peoples? How can we change that? Yeah, we need to maybe think a bit differently. So that's the great thing about human beings. And so I talk about it like operating systems, right? So, and that's again an oversimplification when we're starting to think about these things, different ways of knowing. And in our training, so my first like early scientific training, I had an NSERC fellowship after my first year at McGill, and I was working in a molecular biology lab. In the break, if you're curious, I can tell you about yeah, some of the silica gels and things like that that we used to use to do our analyses. But yeah, I think that at least we talk about translational research, but in that kind of training, we don't always get training like in social theory. So then we rely on lay social theory. And yeah, lay social theory is very simple, right? So lay social theory, like about culture, might be like what we eat, right? What we can see, right? But you miss it. And luckily, we have a bit of a diversity in the room. So some of you understand this, right? Like for me, like as a Métis Cree woman with an unbroken maternal kin line, right? It's actually like I come from a social system, a civilization, right? That's just as complex as the social systems and civilizations I come from on my dad's family, right? That were mostly from Western Europe. Okay, so one tool to help us start becoming more aware of how we can make it through this world, like as human beings, maybe a little better without like killing each other and ruining the planet, is to think a little bit about where we come from, right? And to think about like how that influences the way that we think. I've been a family doc for 30 years. So I was happy. One of my first academic job was training other family docs. So I was in the days of like evidence-based medicine. The Cochrane collaboration was building. I think some of you might be clinicians, but basically what we were trying to do is understand that there could be experimental design flaws, like new technologies were good, but they could also be harmful. We could overuse them. So that we should study them to see if they were actually helping people and then try to translate that into our clinical practice, right? So I think I was pretty good at that. It was actually easier, I think, than some of this work we're going to do now. But the other thing that was good is that I remembered that okay, so I know a little bit about this. I bring this specific technical knowledge to see the diverse patients that I've cared for in cities of Ottawa and Saskatoon and Toronto, and then in diverse First Nations, Inuit and Métis communities in those cities, and also in northern Saskatchewan and Ontario. But I know a tiny little bit, but people live in their bodies 24/7. So like with respect to like applied Indigenous health research, like we had the patient-oriented research going like 20 years before it happened. So we don't do research, right, without taking into account like the people who we are now partnering with. And see, that's the interesting thing about knowledge systems, because so this becomes a party for the CHR. They reach out, oh, you could, hey, Indigenous scientists, let's do some spore. And I'm like, well, we've been doing that for 20 years. So why is it that that gets ignored, right? It was kind of like when the CHR wanted to do global health research. And then we're like, oh, well, we've actually been working together as international Indigenous scientists already, like for 10 years. Would you like to hear about how we did that? So again, it's just a tiny piece of the puzzle. I'll come across as passionate. Sometimes I'm a little worn down. I saw that there's a document circulating in this university about civil discourse. But hopefully my passion will draw your attention, and I don't mean to be angry. That's why I'm running, so I can get rid of some of that frustration. I think all of you are good scientists, right? So if you saw people just making scientific errors over and over again, right, in a place of science, then you might be a little frustrated. So we talk about where we're from. So this is the Saskatchewan River in the fall season. So I go there regularly. I'm from like people that have traveled along the Saskatchewan River for hundreds of years on my maternal kin line. It's quite amazing when you think about it. I'm tired because I went to the Raptors game and I'm working, giving these talks and having workshops, and then I'm flying to Saskatoon on Friday. So, because we have a family ceremony actually to honor my cousin that passed, and he was still quite young. So 1 year after, we have a giveaway and a feast and a ceremony. So sometimes I'll be like, oh, now I have to like pack and do my laundry tonight, and I have kids. But I should think about my like ancestors, like those grandmothers and great grandmothers and great great grandmothers who would travel, like they would be traveling from like St. Andrew in Manitoba to like Fort Saskatchewan in Alberta, right? Like by canoe along the rivers, but with their like 10 kids, right? Like, so it's like, okay, maybe I'll be able to make that trip. But also just to say like that thing, and so a lot of like biomedical processes are about removing and decontextualizing things. And that's important when you're working on a bench or you're working with a test tube, right? But then when we come to the human element and we're trying to figure our way through this world, yeah, then we need to start maybe contextualizing it. Wouldn't that be amazing? But still, rarely now, I think in kind of qualitative social science research, there's room to contextualize. People assume that it's safe at this university to like contextualize. I don't assume that for everybody here either. We like to talk about in like First Nations, Inuit, and Métis communities, a question we'll say is where you're from. Sometimes it assumes like this stagnant Euro-colonial place, right? Like one place, even though I know my ancestors traveled everywhere. I'm like, whoa, where would you like me to start? It's like the whole prairies, right? I'm a half-breed, right? Like, so we got something called half-breed script. So we had a war at Batoche, a civil war that we lost because we didn't want to sign the treaty. So some of my ancestors signed treaty and then they gave it away because they were in a disagreement with the Indian agent, right? So yeah, that question is mobile. But then we have this thing where like settlers from Western Europe, right, who have been here for a long time, then they might like ask this question, where are you from, to like racialized, like newer settlers. And that's not a safe question because it can be taken as an othering. So anyways, the great thing about humans is we're complex. So I'm just going to try to speak for a few minutes then. So the cultural safety is just what is this? And I think the good news is I think that Dr. Gabriel has set like a good landscape because, but I'll help with a little bit of the terms. And then also, why is it relevant like in mitochondrial research and clinical trials, right? Because a lot of people are like, oh, I'm a scientist, I don't have to worry about that. And hopefully you're all here, so y'all think it's relevant. But then this thing that I'm talking about, and don't be afraid, that's the thing, like how many people know, like, and like have taken courses like in social theory or epistemology. I'm not trying to use fancy words. Okay, but that's okay because you know some things. We could talk right away. Even I worked in Barry Glickman's lab at York University in the summer of 1987, right? Like you'll have a whole bunch of knowledge I don't have now, right? Like about biomedical engineering and molecular biology. So it's just, and we say things in fancy words, but every single one of you now, right? Like is practicing, how could you tell me in the elevator, right? Like, or even somebody that hasn't spent like 15 years in like postgraduate and undergraduate education, what you do. So that's just knowledge systems, ways of knowing, right? So the main knowledge system you're using probably is a positivist, like scientific hypothesis approach, right? So that just means that like you're like only counting things in that you can observe, right? Or some super like microscope or other amazing imaging system that you have can observe, right? And you're trying to remove extraneous factors. So you're actually purposely decontextualizing. And when you discover the big thing, then you want to see if it's generalizable. But that would mean, could it be repeated, right? And you're trying to be very clear on that. I think maybe, and that's what you can think about, right? Once we start having things at the interface of knowledge systems, so how many people have thought about complexity theory? Yeah, okay. So that's cool, right? And what's important in complexity theory, like as we use it, like in health services, and there's actually like primary care researchers that think about it because we're always at the interface, right? So it's just, and that's why I use the operating system analogy, like Android and Apple, or, but you guys are smarter than that, but even a certain programming language, right? The logic of most computer programming languages is similar. That's why, but actually, if you did think about an iPhone versus like a Android phone, there is lots of layers, right, that are different. That's why they're not compatible, but they're both sophisticated. So maybe the operating system, like of the diverse and sophisticated Indigenous worldviews, like a lot of that's based on like observations in the natural lived environment. And I think with AI, these are very relevant discussions because we're all going to be using AI in our work, right? But AI is going to reflect the knowledge system that it trained on, right? So that's going to be very interesting. So it's either like it's going to perpetuate like hierarchies of knowledge, right? But it may also reveal them. So this is why I think it's important. And if you really want to work on making mitochondrial research relevant for First Peoples and for all peoples, and just be clever, right? Start thinking about what are the basic knowledge assumptions that you use in your work, right? And then what are some different knowledge systems? And like start to think about, because if you just made like some error, like, so say you said, well, I like to tell an example as a practicing family doctor, like, and we talk about healing and people do want their doctors to spend time. So on occasion I've dreamt about a patient, right? And then my teachings might be, well, I should pay attention. There's something happening. And you could say, even if you didn't believe in like metaphysical realities, that like the brain is processing. All of us would probably agree and have exposure to some basic neuroscience that the brain processes. So maybe there's something I missed. There's a lot of things when you see like 40, 60 patients in a day. I could never, well, if pressed and they were really sick, I could see 60 in a day, right? So the next day I would pay attention, right? But if I was to tell the patient or my college or my colleagues, oh yeah, I dreamt about that patient, so I did a chart review and I'm changing up their medications, right? Like people would be like, whoa, that's like weird. So I think that what we want is a world where we can switch between these different ways of thinking. And that to me, if we can be humble, like in our science, right? Like even though, like the great thing about every scientist in this room and every leader in this room is I think you're really good at what you do, right? For those of you that are bench scientists, STEM scientists, you're really, really good, probably mostly in one knowledge system. And that's great. We should hold that up, because if we're going to do knowledge work, we should do it well. But then just be aware there's other knowledge systems, and that's really exciting. And some of us get really excited about being at the interface. All of us are probably doing like interdisciplinary work, right? Because as we talk about translational science, so one thing is if you move even from the wet bench, like to a clinical trial, and then you move into like actually policy and clinical practice, it's bad science if you don't say, oh, okay, I'm in a new context. I'm trying to solve a new problem. What would be better, right? So some of you are going to invent medicines that I could use in my family practice. But if I just in my head said, okay, now this is a new discovery, it's like the best medicine for this mitochondrial disease, and I didn't think about the patients that I'm seeing, can they afford the medicine? Do they trust me? Because do they think it's like a weird nutritional like experiment? Why would I try it? It's like my mitochondria. So those are all different skill sets, right? But what we want to say, and what I'm hoping you'll do, and that's why I'm trying to talk about worldviews. And first of all, I know you're all clever, so I'm trying to engage you to say, okay, that's cool, right? Like, and I'm going to stretch my brain and maybe read about a different worldview. But then if you're reading about, like a lot of times people are like, oh, Indigenous worldviews or community worldviews, those are lay science, right? Like, and it's still in the peer-reviewed literature. So you're missing something pretty cool, right? Because to survive for millennia, like on the prairies in the wintertime, right? To travel thousands of kilometers, like on these river systems, there's some pretty rooted and sophisticated knowledge, right? To do those kind of problems, right? To live in a ecologically balanced way in the prairies, right? Or to navigate those huge terrains. Okay, so I think Michaela's kind of done the first objective, like why should we be concerned about Indigenous cultural safety? I love to show this, like, and for us, we're passionate. I'm passionate because actually, right now, First Peoples are still not able to thrive in their lands because there's a collision of knowledge systems and ways of being, right? And I don't think it's morally okay for one group of people to think their knowledge systems and ways of doing things are better than another group of people. But so I'm just, if you are somebody who's kind of suspicious or never thought about it or thought, oh, well, that's like just culture, that's like what there's good restaurants to go to, and I know those things, versus it being very concrete and applied. I'm just asking you to think a little bit about that. But it has real implications. So there's some pretty good science, like bench science, very intensive bench science around the clock, right? That went into getting us a COVID vaccine, right? But what happened is the 100,000 First Nations, Inuit, and Métis people that live in Toronto, census is undercounting us by a factor of 2 to 4. and I've shown that 5 times now, and we publish that in peer-reviewed journals, we're not accessing the vaccine. The government was saying, oh, First Nations and Inuit vaccine rates are like over 90%. They said that, or Indigenous vaccine rates, but they actually were using language that was excluding about 60% of the constitutionally recognized Indigenous peoples, because they were just talking about First Nations people on reserve and Inuit in the north. That's one population. So one thing is we have actually the largest community of recognized First Nations, Inuit, and Métis people in the province of Ontario, right here in Toronto. But only early days, 30 to 40% of those people were afraid to get the COVID vaccine. So we had an event here. Michaela helped with that. We set up vaccine clinics. I spent a lot of time as a known Indigenous healthcare provider trying to help people understand that this vaccine was safe. So, and you can just imagine, so we don't forget when horrible things happen. So people are afraid to come to the mitochondrial study in clinical trial, right? And when people aren't able to access health services, then we get these huge disparities. So I started, and Michaela said, the Well Living House, the center that I had the pleasure to develop and co-lead with community partners and amazing scholars like Dr. Gabriel. It started when I was a younger family doctor and attending births and teaching other family docs in training how to attend births. I'm just why would that be in Canada, right? That our infant mortality rate, since if you have public health training, you know that infant mortality is actually a really good indicator of population health and well-being. Why are they 2 to 4 times higher? This screen just went to sleep. So I don't know. Yeah. The preview monitor went to sleep and then this stopped working. Oh. Now. Are you able to advance the slides, or is there another thing to advance the slides? Maybe this logo. Yeah. Yeah, perfect. That's good. Okay, great. Okay, thank you. So Mikhail has already talked about the gaps then in this health and social services, and so this is, don't worry, we're gonna get back to it. I know I like being psychologist, Dr. Gabriel, but again, she's talked already about how the police. So that picture, another picture, this is back on right? A rooted social location for me. And that's my lodge sister, Christy Belfort. If you want to see something, look up Christy Belfort's art. And one thing she did, because we're action oriented, right? That when I said I read you all, it's actually they're asking for Algonquin languages anyways, is so to honor the missing and murdered Indigenous women and people like girls. She did installation art around the country in partnership with local people. To do be the top of a moccasin, that's called a bear. But the sad thing is that this is some ceremonial cloth going down to the Saskatchewan River, and then it's thousands of moccasins, right? But right, it means that we don't have a bear that is going to protect people. And then, of course, many of you heard about it. And that's the report that is down, right? It's some actual First Nations now have a beneficial plan, and it was referred to by a primary care provider because they needed a pathway. And he got everything emergency room and and he was had anywhere he can find. But they thought that he was homeless. He was about 6 years very next story with the other story. We can, great, but I guess so that's the good news is I don't think anybody wants that healthcare. So that's why I'm so passionate. Okay, what kind of training? How can we do? Right? most of us now, like, so we're talking about routine clinical trials, like mitochondrial research and engineering to make it socially valuable for indigenous people. So unfortunately, it's important to kind of understand this, but the other part that, and in fact, and the good news is, so we've already highlighted this, we've been told what we need to do by the Truth and Reconciliation Commission, and that's going to be here, but we're in court about to file, and obviously it's not for some facts. But he ended up making sure, remember the news with the Truth and Reconciliation Commission was a hard job. So they had a couple leaders step up and step down within their group. So he listened, because that's the thing, and we did our little ceremony. So yeah, maybe I love thinking about complex, like scientific protocol design, like in human social context. So who knows what I would have done, like if there wasn't like these gaps. But I'm happy full state. I get tired of part of emotional work. But these are the things that they said in help, like all of like tens of thousands of testimonies. So yeah, that's the case. So I try to get in. Hopefully, most of my work is well aligned, like with the 7 things, and you can see some of them are around cultural significance. So in that like CRC, I get to try to be creative. Everyone's good at VR. We're trying to actually right now, we're at Toronto, we're working with Dr. Gable on using VR as a tool, a practical tool, so that people can practice Indigenous cultural safety skills with labor and delivery. And in years, Dr. Gable also talked about it. All of our families are still getting instructed in labor. Okay. So what is cultural safety? It's not like you get a ticket or something. It's speeding, like in the land of collisions between different ways of being in the world and the history, the ways that we've come together in this amazing land, right? And we're family, right? Like one time somebody did come in and said, well, what would be like, what would be a good outcome, like a truth and reconciliation? So it's kind of like, so we're big into relationality, like that. So it's almost like we're a blended family, and we have bad relationships with our debt citizens, right? Okay, there's a bad history there, right? So what do we need to do? Lisa Boben, amazing self-taught visual artist, PhD here at UT, and so she did this image for the medical school a while ago. So this is building a relationship, and what you see in artists, good news about artists is they can help us understand different movies and complexity, right? So this is her image about what it might look like if my biomedical world in my training as a medical doctor was coming together, right? With the world of this Deming woman that she's drawn in that picture, right? So then we're communicating, and both of the knowledge systems are honored in this, and then you're, right? I'm thinking, if we could actually, like, to me, it's like our natural global ecologic diversity, right? So that knowledge system are actually part of the natural biodiversity on the planet, right? So that's why we have to be careful of what hasn't been done, right? So I'm not saying, because that's happened to me already, like people said, well, these Indigenous ways of knowing and doing, like our Dhamma, and like our Catholic, right? Like, so that against the law. My grandmother didn't teach my mom to read, so then I can't teach it well. But it's a cool language, like the word bundles and the concepts, like the languages about verbs and action, right? And in a language are the kinds of principles. Just like the language of math is a cool language, right? Language, like a molecular biology is a cool language. Anyways, basically, some people have heard of who's heard of like cultural sensitivity. So for my whole career, I've been talking about that, and this is all just words in English, so it doesn't have to be a semantic exercise. But most people might have heard about, like in the US, they said they have a cultural melting pot, and in Canada we would have a cultural mosaic, right? And that we should try to be respectful of culture, but we don't have training like in cultural studies or social sciences. Like I said, then we just went out and about, and I'm not thinking that you think this, but it might be, well, what is your culture, right? Something. Even for a lot of people on this, they'll say they're Canadian, right? And it's not necessarily safe. They would move around. My mom moved from Saskatoon to here in Toronto, and my dad, but going on other territory, right? So it's complex. I like that. I like that in family medicine and community medicine. But in my practice, it's like I'll see people like with tens of thousands of different sociocultural, linguistic like phrases. And so part of my what I bridging that. So I bridge the complexity. But yeah, this sensitivity, I make a joke, it's like, oh, right? Like just like we're sensitive, the sweetgrass was where I didn't really like the smell, but well, not. So it doesn't really celebrate or rejoice difference or make room for difference. And then in healthcare now, and it still gives people say I'm competent. And I'm like almost 58 and I'm barely competent. I grew up with my mom and my grandma. I'm not really, I don't know that I would consider like, you know, the exemplar like Métis, like woman, right? Like in my own culture. And yeah, I don't know. On my dad's side of the family, the exemplar was probably feel that whole miserable. Anyways, so I believe in cultural competency. So a cultural competency would be, oh, I'm self-reflecting now, right? Like then, like it's okay. I don't have to be an expert in all of those tens of thousands of patient presentations, and it's kind of arrogant to assume I'm 50. And what I want to do is just know myself a little bit, try to understand my operating system, and try to be kind, try to observe, and not to be afraid. Like, oh, I don't really know very much about that, right? Which is also hard because when we're in our scientific disciplines, right? Like, you know, when I was reapplying for my tier 1 CRC, I wasn't writing the application. Oh, I don't really know very much about that. I think some of those processes, they kind of build narcissism. We'll get there. Okay, so this cultural safety is really about self-reflection, and it goes beyond some of these other things. So that's why we say it in that way. Okay, and so here's what I just said about knowledge systems, and this is a slide I've shown a zillion times. I actually tried to contact the person to let them know, but I didn't hear back from him. But this is a cartoon about a very famous legal case. So all disciplines struggle with this, but yeah, in law, we talked about there's a collision force between like Indigenous systems of justice and government, which are very diverse. The sociolinguistic diversity of the Americas before European colonization was an order of magnitude more than all of Eurasia, right? And that's, so here, basically it's called the Delta decision, and it's the first time in a Canadian court of law that local Indigenous ecologic knowledge, right, and history was recognized as that, right? So before that, it was all the settler knowledge of maps and but then I'm just like, okay, so I'm finding stuff to do more on what happened, like something happens with the plane, there's emergency, I won't say like that stressed out. But all of a sudden we're in the prairie like that. And I don't think that makes Chinook wind from Calgary hit Saskatoon. I hope it's cold, right? So we're in the polar vortex. So what would you like? You know, would you like the access to like the internet, right? Or would you like to have somebody of any background that actually knows how to survive on that, like territory and actually is familiar with the land, right? So you got to pick the knowledge system that fits the problem, right? So it's interesting because even this cartoonist, you see that they've got this simple kind of cartoony, so it almost perpetuates that stereotype that First Nations unity, knowledge systems are kind of simple, you draw like a little, like doodle, right? There's nothing like a doodle about knowing how to survive, like on the very winter. It's very practical, but there'll be a metaphysical aspect too. There's also very practical aspect. That's another thing I love about Wellbeing. So here's all the book knowledge. And I love books. I'm surrounded by books. My partner is an Indigenous librarian, so I'm not dissing book knowledge. I'm just saying, okay, let's figure it out. So you would think people have lived in these places for over 10,000 years, like and survive. They might actually know the territory, like a little better, but the Canadian legal system didn't recognize that until relatively recently. But the Gitscan people, the First Nation people, they wanted peace. And then this is my favorite quote. It's from one of my best friends and my urban sister, Shirley Bourgeois. She's a prof at ours, and she's a Canadian wife. And she says the problem with universities is they teach us that we know better, right? That narcissism I was talking about. And you each do know a lot, like about little pieces of the puzzle, right? But we have to bring together all the puzzle pieces. And then just to say, as Dr. Gabriel McGill alluded to, if we have all of our own books around like Indigenous methodologies. That's one of the most famous ones by a Maori scholar, Smith. Okay, so these are the complex questions, and I think we're going to break in about 10 minutes. And these might be hard off the cuff, especially since most people that they haven't taken like a philosophy of knowledge course or whatever. But you do know, like, so, and this is random, doesn't it can be a clinical practice. Like, so in the studies that you do, I bored these slides a bit because I presented it to an audience of like 500 people from a clinical trial. And don't worry, in that room, clinical trials went through at their annual meeting. There was only 1 or 2 people that said that they had trained about what their knowledge system was. So even if you don't, you're all here so you care about this day, which is good, but even your colleagues that didn't come and say, well, that's cool, let's think, because it'll make your knowledge translational research will be better, right? Even if you are thinking that this wasn't very good talk or so for the talk. And again, and I work with a lot of very bright Indigenous scholars, and we have social behavioral health sciences, political health. So there's rigorous graduate training, like in social, the grand social theory, they call them. It's like having to argue, well, could we not just have some Indigenous theory, or Indigenous practice? And at first it said, oh no, we had that a grand social theory. We had to actually do that. And I was actually politely supervised because I don't, like, I'm not like bracket. I'm like, we had a grand social theory. Like sometimes when you had to like make your way through an oppressive system and actually like something. They didn't want to have the debate. They let them supervise the student. She was allowed to use Indigenous theories and practice in her thesis proposal and thesis. But so basically, epistemology is just knowledge systems, right? And actually, in the like Métis Cree knowledge systems, like we share, we're empiricists, right? Like there's systematic trialing. Most of the time it's experiential systematic trialing, but over tens of thousands of years. We look at the lived environment, right? Like, so people say like for different medicine, like you can see if another mammal, like if a bear can eat a thing, right? And want to eat, right? But then that's actually, it's more complicated and like a metaphysical way involved, and we also develop relationships with plants as healers. But just to say, it's not completely different. Like we share a desire, I believe, for careful thought, complex thinking. In our stories, we just have to look at our stories, and that's interesting because I think complex thinking has emerged now in our primary education. So, but like people in Indigenous education, again, though, like the traditional stories and the sacred stories from my community, there's complex thinking on little kids are hearing about the way, not like they're in that valley. Yeah. So, and I think that's coming back. And I don't think that we have a monopoly on that. And then ontology is just the nature of reality, right? So, in the nature of reality, for me, there's energy, there's vibration, spirituality. I'm not the one to teach about that, right? So, not everybody would have that view of the nature of reality. When we're in our wet bench, or when we're in our clinical practice, we're not necessarily, even if we believe in that, you know, we're not necessarily talking about that. So now I'm starting to talk about what are some of the underlying knowledge assumptions, right? So being a good observer of things that's shared, I think, across most different forms of science that I've encountered as somebody that, did a little bit of biochemistry training a long time ago in Bill, and then did medical school and did public health training at Johns Hopkins. And then it's done a lot of work probably as a social epidemiologist. So trying to bring social theory now, I would say I'm Indigenous, trying to bring an Indigenous what we want to like population health and studies. So what kinds of questions like are best answered by the kind of science you do, and what other questions are relevant in your field where might you want to pull in some different science? So we're all here today because I think one of the underlying questions is how can we make our research more socially valuable to first people? So that's why, you know, Michaela is here and we're talking, okay, well, there may be some different kinds of methods and ways of doing that, and there could be some limitations, right, to the science that so well will help us figure out like how can we be mitochondrial and right, like how can we take advances in AI now, like that are making our ability to identify like genetic mutations and like then complex pathways, right, to like that in like once you're starting to go from I think a gene to a drug, right? Like when you like AI is going to help us. There's no way it would take like 2,000 years to do that number of calculations, right? So we're actually, those are good tools. Okay, so I think maybe in this talk it has like a little example, like because I mentioned that that one arm where I'm actually very interested in the patient-oriented impact of all these different kinds of antibiotics and cultural safety outcomes. Remember I said it bothers me when we do bad science, like whether it's the Indigenous science, so one thing that bothers me or that I'm passionate about is finding better ways to understand what are the right? So we all do different kinds of bias training in our work, and then there's a growth, this huge growth in the amount of Indigenous cultural safety happening. But most of the evaluation asks people how did they experience the training, right? Which is good, is to do this kind of work, and I'm kind of currently we're kind of engaging they were built set a foundation because these are wicked problems, and like they're problems that can resonate in different ways for people to connect with, right? So it's important that people feel safe, right? Across social locations if they want to advance their cultural safety. So we have to feel okay and safe. Actually say, oh, human beings are flawed, right? And societies are flawed. And no matter what our intentions are, like we tend to be rooted in group and get programmed by stereotypes. Okay? So we need to, so the good news is we can interrupt that. We we can retrain our brains. And, but the thing is, depending on the kind of training, we have to check to see if our brain needs it. And we should check, because if we're spending all this time and the outcomes are really bad when people with untrained brains, like they get mistakes and they just ignore like a man in the emergency room because they assume that he's homeless and like trying to shelter from weather. That was a mistake that like over dozens of people made. Then we have to retrain those brains and systems. So then we should actually test people. So the next time somebody comes in that looks like that, like, are we like maybe training our brains so that it's like, oh, okay. Because I love to stereotype, right? Like, and we know from like social psychology that when a stereotype repeats itself, we feel good, right? There's actually get like a little dopamine too. That pattern work that feels really good. But that was a piece of it. It's uncomfortable when you start, but hopefully, like it's this bit uncomfortable conversation, right? So the thing that I'm passionate about is adding to like, oh, I didn't like that training, or I didn't like that. Because I think the really good cultural safety training don't feel like, right? Because they're stretching. You have to become comfortable with discomfort. So, and I also know as a scientist that if you're trying to change clinician behavior, especially physician behavior, right, you should never ask us, because we know scientifically that self-reported physicians around behavior change is very unreliable, right? You have to have somebody objective. So that's why instead of we had unidentified standardized patients go see people after they had the training. They didn't know what was going to happen. We can prepare, we debrief them after they all stayed in the study with that understanding logic, right? And then what I showed was that actually people who had taken cultural safety training compared to people who hadn't were 4 to 6 times more likely to be highly recommended by those standardized patients who we standardized and calibrated through repeated training to make sure that their assessments of the interaction are valid. And we do on other studies that have shown that you can actually train standardized patients to do the assessment, and it's just as good as that. So that was really fun. But before that, stop. Let me, so don't get alarmed, like if this is just a little, because I didn't, you can read the study if you want. But action, so Smylie, ceremony I'm going to go to tomorrow. But this thing about action is also an important thing. And see, all of you as scientists care about that too, right? Because you can say, oh, I had a great study, right? And you'd be like, okay, I want to see this, right? I don't believe it until I see it. So just this idea, it's good, like, to want social change. It's good to have passion against sorrow. It's good to feel, you know, we don't always have time in the busy schedules. But like in my language, there isn't a word for reconciliation, but there's a word for setting the right. You'll hear about this if you look at just a little bit about Indigenous justice, you'll see restorative justice, right? So if I did something wrong, like my ancestors don't say it's sorry, like what she would want me to fix that. Let's say I had an accident, like, and I hurt somebody else and they were not mobile, then like the restorative justice would be like I would make sure they and their family were taken care of, right? So that's the hard part. Words are cheap in science and society. Okay. So things that could happen, like you could, so because I've shared like from my specialty, right? That there's actually some kinds of cultural safety training that are better than others. So like have a look if you're interested, but that's something that you can do right away to kind of extend if you're interested in this different way of thinking and being in the world, like a way to, that you want to kind of dig down a little bit into your own social location and and build some skills to make your way through the fact that as humans we're uncomfortable with difference, and then we tend to sort people by whether they're simple or different, and then the worst thing is that we treat people who are different than us not as well as people who we think are the same. And the weird old thing is, actually, and that's our call from the US, Dr. Wilcox here yesterday, like everybody in this room will have something in common with each other. Who knows, some of you are like Star Wars fans, there might be one or two other marathon runners in the room, right? Like some of you love certain kinds of music or food, right? So you can find that, right? So there is a lot of similarities across these old style ways that we have that have also then been socially programmed to design someone's life as versus different. So then like reflect on this. So that's the kind of reflection stuff. But that third one was the one I really am excited to talk about, partly because I like it. So maybe that's my own bias. I like being in between like different kinds of things. That's where I find like excitement. But yeah, I'd be pretty curious and interested in, I'm pretty sure, the different kinds of sciences you do too. And then the other part though, this equitable distribution of resources, that part. But that's the thing about actually doing something, making things, right? Sometimes they don't give up things. So I thank you, because what you've done is you've given up like an hour of your time and time of the precious commodity to kind of listen. So basically, I tried to, hopefully now you understand a little bit about it through this word Indigenous public safety, what it is. I think that why it's relevant, what we got, we had already talked about that, but you can continue to think about that, right? And then, like, what are some of these gold standards? So hopefully, to me, that's like getting brains active around just different ways of being in the world and understanding the world. And then, yeah, I gave you one example. So I'm happy. I know that there's lots of other good things coming in that haven't broken, but does anybody have any questions or share? Maybe ask you to deal with that so that you don't have to put sitting. Yeah. Well, maybe we should. Yeah. Thank you.
Thank you. When you were talking about the story about the man that unfortunately left in the hospital, it really speaks so loudly to me, because I come from Brazil, where I have seen my fair share of poverty that I hope you have not have seen it in your life. And when you said he was left because he looked like homeless or drunk, I'm like, but he's a human being. It for me, what came in my mind is, we all came from the same mitochondria, remember that? So in the end, it doesn't matter. For me, my mind was going back to my roots on my own land. It's like, it doesn't matter if he looked, he should be treated independent of that. And I understand what it came in this person being an Indigenous person, but it should never matter in the mind of someone what he look or not look. It kind of really strike a nerve on me when I see that, because we should not be looking at that, especially if you have a healthcare professional. That should never be part of this story. That I hope someone one day will teach our healthcare professionals that it does not matter how you look or where you come from or who you are. You should be treated equally.
And so that's one of the wicked, like scientific and like social scientific problems, because I believe that at least 80% of the healthcare providers that like participated in all things Aspen have a similar commitment, right? Like, I mean, actually also, like, I don't believe they woke up that morning saying, I want to, like, not respect somebody's humanity because of how they look. I don't believe they went to, like, nursing school or, like, medical school for training medical receptionists, because they wanted to dehumanize people. I believe they wanted to help people. So then it's like, well, how did that happen? And I got to hear from people, right? So it's a cognitive problem. Their brains in that context had been mistrained, right? So that's the big crux of it. Nobody wants to do that. So, and where it's relevant here, because you all want your science to be valuable to everybody too, right? But that's what gets you up, right? You would want it just to be valuable, to socially privileged people. You don't want your science, and some of us are really committed to science because we think it could help us get through the world that exists where there's injustice. Right? So that's the beauty of a scientific method in many different kinds of scientific methods, but they can perpetuate, right? Because there is this broad context, and it's in a society where both so that there's a tension between there are just some mean people out there who are hateful people, and we're hearing a lot about hate and getting stirred up, and even some of that because the world is changing, and you can make a lot of money on YouTube if you're a hater or actually creating false dichotomies, right? Versus bridging dialogue. And then one thing for me too, when I'm on my laptop and things so I'm delighted today to track in a good way they kind of compete for that. So we're building dialogue in relation, but yeah, sometimes at the end of a long day of doing stuff, if I'm making my little protocol and I'm really curious about how I design this in a really sophisticated manner, right? And I can work with students, healthcare professionals or medical students, right? But yeah, well, how would this fit? This train, how would this lecture sit with people? Luckily, Dr. Hugo, because we're not just here because we want to share history, and it's been kind of a tough goal, but we don't the outcome. And we're thinking about it is okay, how do we prove it together? So thank you for that comment, but I actually don't think that those people were bad people, right?
Yeah.
That they were good people working in a system that was problematic in a world that was problematic, and I'm very curious and passionate about how to address that. But that's huge, and actually it's going to follow.
Yeah, I'm going to add one quote that my grandma used to tell me since I was very little. Always treat everybody the same way. You never know who's going to be your boss one day.
Yeah. Any other questions?
It was around your experience with COVID and just thinking about, for us, what lies ahead around that knowledge dissemination. So you had mentioned that during COVID and the vaccinations and the Indigenous community coming out, and how it was important to speak with them, talk them through that vaccination process, answer questions. So I'm curious, from your experience there and us taking learnings and collaborating with the Indigenous communities, what did you learn from that experience that we could take forward in how we approach the communities around the work that we're doing around the mitochondrial transplantation? There's that transactional knowledge sharing that I think we're quite accustomed to, of here it is, we present it to you, you absorb it, but not every community disseminates knowledge in that way. And thinking of the Indigenous community, what do we need to be mindful of early days in how we are going to disseminate that knowledge in a different way?
So I think it's about social contact that one problem speaking that there's a dense cut that's science generally, but just based on what you've heard from Dr. Gabriel, yeah, scientists aren't that. We've been abused and exploited, and there'll be more discussion. So then you're almost like, okay, well, that was my relative experience. People don't like us, like a lot of our community won't go to the emergency room here, right? Like, so they're done that help because they're afraid. And then social media blows things up, and even if it was just 1 out of 100 people, but it happens a lot, not, right? That it's treated badly, it makes sense to avoid, right? So I guess you're all probably thinking about, well, I'm going to translate my science in a world where, yeah, there's like this anti-science retort. So just magnify that a little bit. One thing is then if you have a pre-existing relationship. So I mentioned because I've practiced like for a while, and so I tried as much as possible to build on pre-existing relationships. We set up clinics and a big qualification for people coming to the clinics and full on people with pre-existing relationships. Midwife, right? So okay, this person attended my birth, right? Indigenous and a lot of midwives. So now they're getting room because we want people to be able to have like room to decide and be respected in their decision, right? Because avoidance could be a good decision, right? Like there were vaccine experiments in the residential school too, right? So yeah, people were afraid. Some of you in the room, I'm in the room, to have like already access COVID vaccine if you weren't on the healthcare providers. First Nations, they would have before on it was so, but then people were like, oh, they're getting into us first because they're experimenting on. Yeah. So it's just understanding that, Kathy, Dr. Gabriel on your team and viewing that. It is realizing that it won't get fixed, in one kind of study, right? But this build, so think about what it might take, like to bridge broken social contracts, right? And rather than just blaming communities of people to say, well, they're just paranoid, right? Like have a deep kind of understanding and really hold up a note, right? That's okay too, right? At least there's a conversation, and that could be really important. All of my research I do with community partners, so it's funny because when I go to a community, I say, hey, I've got this great thing that we can do, like a new thing, and then the community, so you might be doing that too. Do you want to work with us on this amazing like mitochondrial foundation? And I'll be like, no, right? Dr. Rothstein wanted to do bariatric surgery trials, like in First Nation and Métis species with obesity. The council of grandparents and they respectfully said, no, we want to work more upstream, right? So, but you can actually feel good about that, right? You can say good, right? Like that's that whole thing that midwives have held up now, and now we do that across the board, like respecting autonomy of decision making. Those are just so it's taken a long time for things to fall apart. Like so bridging trust. I was at a meeting in Yellowknife last week, and the Minister of Health is an Indigenous Minister of Health, so she kept talking about the whole bridge trust. The meeting was about building a new framework for Indigenous across Canada. But and then you have to work together because it only takes one breach of trust, right? Then it's going to ruin a whole lot of work, right? So this commitment that we have and that we're all here, but it's going to take time and go slowly, like find one partner. And, yeah, we'll continue to dialogue, right? Okay. Other questions? Yeah.
So in science, we try to, thank you. So in science, we try to be like, go from like very simplistic way to more complex. And for most of the time, we're like, okay, just keep it simple because it's like really, really hard to like especially when we bring like more ethnicity and everything. So my question is like, how do you add more complexity, right? And like, how do you really like, like get to the next stage. If you're like, okay, so many Indigenous people, they're living in like a different, like, maybe they're living here, maybe they're living like, in somewhere else, their nutrition, their socioeconomic status, and all the other things. How do you incorporate that, right? And I don't know if it's a nice question or what, but yeah, like how do you add that complexity?
One thing I would say is I would encourage you to locate the kind of science that you do. So one way I've been asking the question is, in the kind of science that I do, right, I try to keep things in. I understand that, even as a social epidemiologist, I trained at a hospital, right? So it's like, you want to design a parsimonious model, right? That's changed a little bit because the math has caught up a little bit, right? So these dog diagrams, I mean, that's fuzzy logic. That's not what those like world-class epidemiologists and clinical trialists taught me. That was 20 years ago. But I respect, so yes, your job, right, like is actually to look at one thing at a time. So now, luckily, depending on where you are, I don't know exactly what your area of specialty is. But one thing is, if once you're getting out of what you know, because even this whole thing about ethnicity gets added, but like that's actually bad science, because like ethnic groups are socially constructed. So what a particular ethnicity has to do like with genes, like and like RNA and proteins, right? Is like actually like there is a lot of diversity, right? So I mean, you can have certain gene lines, right? Like but there's more genetic diversity, right, within an ethnic group. That's where there's been some bad science, like the tryptophan gene has been recounted, and again, luckily genetics is helping us understand that, right? So, if one's all of a sudden trying to factor in like race and ethnicity, like into a population health model, what's common is the experience of racism or dehumanizing, like our social exclusion. Right, that's what the marker is. So we're criticizing that, like in social and Indigenous epidemiology. So two things. That's like, one is to say, okay, well, that's the kind of science that I do, right? But other people are doing other kinds of science. That traditional knowledge keeper, right? Like who is monitoring all the changes in the Iceland maps, right? Like in Inuit territory. They are doing a different kind of science. And your two sciences might actually be related, right? Because they're both built on careful observation, right? But there may be some differences. So the other piece is to say, okay, so now I want to deal with complexity. How can I do that? Then you need to find somebody that can help you deal with that complexity and that particular complexity who's an expert at that. So that's like really transdisciplinary. Does that make sense?
Yeah. Thank you so much.